Hello, good afternoon. Welcome to this web session organized by ESCMID on COVID-19 treatment, included in the new series of web sessions that ESCMID is undertaking. I'm Jesus Rodriguez Baño. I'm infectious diseases physician from Spain. At this moment, I'm past president of ESCMID. My co-chair is Evelina Taconelli. She does not need to be presented, but Evelina is infectious diseases physician and professor of medicine in the University of Verona. She has a last minute issue and probably will be able to join us sometime later. But in the meanwhile, I will take care of the coordination and I will chair the session. So we have a fantastic panel to present an update on different aspects of treatment of COVID-19. We will try to cover mostly in the first talk, the update on drugs with that specific antiviral activity. In the second one, we will deal more with immunomodulator and immunosuppressors. And in the third one, we will deal with specific aspects of patients under mechanical ventilation or in general in ventilated patients. And we have, as I said, a fantastic panel of experts that will lead us through these three big issues. I will be introducing them one by one when they have the opportunity to do their talk. Our intention is to have the discussion at the very end with the question and answers, so that all our three speakers can participate in every single question. But if there's something, and we will be collecting the question during the whole web session, but if there's something very specific for any specific presentation, we can deal that in the moment. So our first speaker is Justin Panat. Justin works in Bichat, Claude Bernard, and Paris Diderot University in France. Justin has been coordinated several activities related to COVID-19 in France, and of course is very much experienced in the management of patients, but also in the organization and the management of some clinical studies. So it's a big pleasure to have you, Justin. All for you.
Thanks a lot, Jesus. It is a pleasure for me to be here with you. So I hope that you see my screen well.
Yes, we do.
Thanks again. So I have to talk about an update on drugs with antiviral activities. So first of all, just now that everyone knows is that COVID is not one disease. And this slide show you early infection, pulmonary phase, hyperinflammation, that all you know. And you have, of course, the first phase that is viral, virus response rates, and second phase, which is more the host inflammatory response. And of course, there is an overlap between these different phases. This is actually the first patient we had in my hospital at Bichat Claude Bernard, and probably the first patient in Europe. And you can see that in this slide that the patient really started to have his pulmonary infection and his pulmonary disease when there were no viral load and there were no actually excretion of viral load in nasopharyngeal swabs. Of course, we started even regarding antivirals with a bunch of candidates in early March to April, or even further in 2020 that you are here. And this is actually something we had publishing CMI, my team, on different drugs that we could or would candidate with antivirals. And now with time, most of them are shown to not work. And the most famous, of course, lopinavir or hydroxychloroquine. There are also some drugs on which there are still some question marks, and some that we are continuing to evaluate. And I will go in more depth over these drugs. I just wanted to clear one matter here. Here I have put the EADSA guidelines that are very recent regarding ivermectin that I'm not going to cover at all, that they say that it should be evaluated within clinical trials. What we have shown in animal models, that if you want to have an antiviral activity with ivermectin, you should use very high doses of ivermectin that are not tolerable and not toxic. And of course, there is also an immunomodulator effect, but that is different. So I just wanted to clear that. I wanted first to start maybe with remdesivir that continues to be used in different manners in Europe. So of course, one of the first trials that we have was the ACTT NIH trial, a double-blind placebo-controlled RCT in USA, in patient at hospital with oxygen saturation less than 94%, where remdesivir was actually compared to placebo, and there was an effect on recovery, as you can see, and time to discharge, and there was no statistical effect on mortality, and there was an effect also, the effect was considered as not very important. And then we had the Solidarity trial that now is published in New England Journal of Medicine, that we, Discovery Hope, have been part of that. And what you can see is that in that study, as you know, there was no impact on mortality. In the paper that was published in New England by WHO and Solidarity team, what you can see is that they did a meta-analysis. And what is maybe interesting in these slides is, although overall they didn't find an impact, there was maybe a trend in the patients with no ventilation versus the patients with ventilation. And you can see that is the overall effect. And even in ACT trial, there was a trend at that with, again, low flow oxygenotherapy, maybe a protective effect, but not in patients on ventilation. And you have the same, although not significant, in the Solidarity regarding that on mortality here. The other thing I wanted to say, it's only one study that has showed data on viral load, and you can see there was no effect on remdesivir on viral load. I look at the last guidelines from EDSA, and basically they still recommend remdesivir over no treatment, although there is moderate certainty, but they really state that it appears, this drug appears to really benefit in those with severe COVID-19 and not in patients on mechanical ventilation. Meanwhile, we have, as you know, the Discovery trial that has now enrolled more than 800, and the DSMB of that trial in January 27th stopped trial for futility. And the results of that trial will probably be published soon, and we don't find anything even in patients at the early stages. Of course, that will be published. So really the practice regarding that is different, but of course, I think that the publication of these results will, and maybe a meta-analysis, will add more to the literature. The second family of treatment, which is now extremely important because EMA is working on that, many European countries are working on that, on monoclonal antibodies. And I have listed a bunch of them. Of course, those who are the most advanced are those from Eli Lilly and Regeneron. We have one study on Eli Lilly monotherapy that was published in New England Journal of Medicine by, again, the NIH team that shows actually that among hospitalized patients, this drug is not active. And basically now, most of the experts agree that the place where you use these drugs should be very early in the course of the disease, in ambulatory patients rather than on hospitalized patients. However, I just think that there are now studies, given that we are using steroids, but also now probably steroids and tocilizumab, we will have a delay in SARS-CoV clearance. So I do think that there is a place for antivirals in hospitals patients and in particular monoclonal antibodies. That's why that the discovery trial, which is under EU response, that in the beginning was France, then becomes France, Belgium, Luxembourg, Austria, Portugal. And now it's moving to France, Belgium, and Ireland, Norway, Czech Republic, Poland, Slovakia, Hungary, Spain, and Germany is going to evaluate probably soon the AstraZeneca monoclonal antibody, which is a dual therapy in the patients who are at early stages of development. However, as I said, probably the use of these patients, these monoclonal antibodies will be important mostly in. So for that study from the Lilly therapy, BAM, that was published, you can see that the effect on viral load in this study is low, 0.5 logs, and only with one of the doses. In this study, which was published in JAMA, you can even see that that impact on viral load is not very clear. Don't look at the blue one, but because that is the dual therapy, and we'll come back to that. But the others, the impact is very low, although we don't know exactly what does viral load decay means and whether it has an impact of the prognostic of the patients. In that study published in New England, the proportion of patients who had a hospitalization or a visit to an emergency department was 1.6% in those on monotherapy of Lilly versus 6% in the placebo group, although that was not significant. There was a post-hoc analysis that was published in a JAMA paper on the same drug, BAM, with different doses in patients age 65 or older, or with a greater BMI more than 35. And you can see that here, there was, in particular with 700 milligram dose of BAM, which is used currently in some of the countries, a significant impact on hospitalization because it was 2.7% on BAM versus 13% on placebo. So data are not that good, but there are some data showing maybe some efficacy. However, the issue with these drugs, of course, and with BAM, it's that it is a monotherapy. And in France currently, we are a little bit concerned. And I don't know if you have seen the data that are in the paper of the JAMA and also some data that are from FDA fact sheet. You can see that with BAM, with different doses, you have an emergence of variance, which is higher than the placebo group, although we don't know if this difference is, of course, significant. And this, in what you can see even more in the FDA fact sheet is that not only it's more frequent, but it's considered some variants like E48.4 that is the allele, actually the variant, that the mutation that you find in the South African and Brazilian that may impact vaccination efficacy. And you can see in patients with high risk, it is 9% versus 0% in placebo. EDSA actually suggests not to use, it's against the routine use, but they suggest that it is reasonable in patients at high risk of hospitalization if you give it early and if the patient, of course, agree. We in France, we have decided, we have now expanded access to that, emergency access to that, that monotherapy could be used in hospital under viral every 2 or 3 days, and really to pay attention on the emergence of resistance while we're waiting with dual therapies. So here I have put now the dual therapy. That is the slide I show. The dual therapy of Lilly has really a higher impact, as you can see on the viral load. As you can see here, the proportion of hospitalization in the same study and the post-hoc analysis was much lower. And what you can see also is that proportion of resistance under this treatment variants is also lower even than the placebo group. So these are more actually reassuring data. However, we should be very careful because BAM and even BAM, in addition and even the Lilly dual therapy is probably not active against South African and Brazilian. So that we should be very careful. Here you have casirivimab and imdivinib, which are Regeneron monoclonals, and one of them is not active, and the other probably active on South African and on Brazilian. And this is also important for the future because this is also becoming available. And regarding the Regeneron, as you can see here, they may have an impact on viral load. The impact is the most important if you are sero-antibody negative. So basically, we are going to start in patient to use these drugs. For monoclonals who are monotherapies, we should be very careful, and we should probably use them really in high-risk patients with very careful follow-up on viral load and on virological sequencing. For dual therapy, at least in France, they are not yet available. They will become available, but probably this problem is less. And I know that at the CROI next week, we will have new data. I just want to say one word also with one other treatment is that, which is plasma therapy, sorry, which can be used. This is an Argentinian study that has showed that when you administer within 72 hours after one set in a small sample size, if you have titers above median concentration, you have much less patients with severe disease, 1% versus 8%. And this is very important. And I know that a very large clinical trial on this is going to start in Europe. The other drug that I want to talk about is interferon. So colleagues around the world, and in particular in France, have showed this paper in Science in impaired type 1 interferon activity in severe COVID-19 patients. So impaired means whether we should or not give interferon. There is this study in Lancet that has been done in actually in hospitalized patients, and it shows that the odds of clinical improvement across the WHO ordinal scale is higher on day 15 and on day 28, with inhaled nebulized interferon. Although they didn't find any difference between treatment groups, and although, as you can probably see here, there are very few amount of patients. But there is now a large study on interferon, and we think that you should give it very early again, after infection, and not for hospitalized patients. There is another study, and also the lambda peginterferon. So this study was published in Lancet recently, 30 patients per group, single subcutaneous injection. Actually, type 3 interferon, the lambda interferon, promote actually a similar activity, a similar antiviral state to that of interferon alpha and beta. And in this study, that was only mostly virological, you had a decline in SARS-CoV RNA, sorry, that was greater in those treated with peginterferon than those that were not. And you can see that the viral load difference at day 7 is much higher than actually with monoclonal antibodies. But of course, we should test that. So I think that interferons are really a very promising should be evaluated. Now, with 3 slides to say that, of course, one of the other drugs that will have results of phase 2 in, I think, April is molnupiravir, which is a nucleoside by Merck. You have here results in France, but we have phase 2 results, and probably interesting in outpatient in particular. And I just wanted to finish about 2 drugs that are very early stages that could be interesting. I just want you to have the name. It will maybe go nowhere. One is nanobodies, actually, that are also a passive immunotherapy. They are suitable lead molecules to harness the vertebrate immune system. They are small, stable, easy to engineer. And that was one of the reasons I want to put this, because we should think about the southern countries and economic to produce in simple expression system. We are just thinking about ourselves. We should be about right there when we are looking for. And also I wanted to talk about DARPing, molecules that it's an emerging class, used already in ophthalmology. They are derived from naturally occurring aneuploidy repeat proteins. And it's possible and can be carried out in a very short time, only requiring the target protein, can be monospecific or linked to peptide linkers. And again, it seems though that this also, it's not very difficult to produce. So just wanted, I don't know that much about these drugs, but things that seem promising. I think that the route of treatment and antiviral treatment is long, but I think that we should continue to evaluate these drugs carefully, robustly in clinical trials. Thanks for your attention.
Thank you very much, Jasdan. That was a fantastic presentation and a lot of questions to discuss. So this is the objective. Now our next speaker will deal with immunomodulators and immunosuppressors. So we have Lenny Derde. Lenny works in University Medical Center in Utrecht, the Netherlands, and she has been very much implicated in the REMAP-CAP trial. She will explain what is her role and her experience with that. So I think we have the perfect speaker for that. Lenny, thank you very much.
Thanks, Jesus. Hope you can confirm that you can all see my screen. And thank you for that. Thank you for that kind introduction. You've indicated my conflict of interest for this talk, which is that I'm involved in the REMAP-CAP trial. So that's an international trial looking at the best treatment regimen for patients with CAP before the pandemic already. And we've now pivoted to also include COVID-19 patient. And I lead the European part of that, but we are 6 regions working together to help find the best treatment regimens for these patients. So this was the title of my talk that I was given. I thought it was a bit long. So to make it a little bit shorter and to make sure that everybody kind of understands what we're aiming to do here in the next half hour or so is we're going to have a look at the immune response as a therapeutic target in COVID-19 patients. That's, I think, what we are aiming to do. And for that, it's good to kind of go back to the pathophysiology of the disease. We definitely don't know everything about that yet, but we know a lot already. The amount of research that's gone into this in the last year or so is just absolutely amazing. And this is a manuscript I can really recommend by Joost Wiersingha and colleagues in JAMA and 2020. And what you can see very clearly here is, and this is kind of the second stage of what Jasdan just showed you, is that in COVID-19, there are a couple of cytokines involved in the inflammatory response, notably TNF, IL-1 and IL-6. There are obviously many more, and it's a very complex reaction. I think in the beginning of the pandemic, we were talking about this cytokine storm, and we now know that, for instance, IL-6 levels are not really extremely high like they are in severely ill patients with bacterial sepsis, but they are elevated and they are implicated in the pathway of the hyperinflammatory response that we see in some patients with COVID-19. And then at a later stage, I think every clinician will be able to tell you that there are other mechanisms involved that lead to the clinical picture of ARDS, but also to coagulation activation and thrombi across the body and even pulmonary emboli. So if you kind of translate that into what is going on with these patients clinically, you get something, and it's very similar to what Yazdan has showed you in his introduction, is some people never reach the hospital. They get the virus, and I'm not saying it's nothing, because they can still have long-term sequelae, and that's definitely something that needs research, but it's not going to be the focus of my talk today. And if patients reach the hospital, they are usually admitted for hypoxia. So older patients are sometimes admitted for other reasons, and that's usually related to their comorbidity. So when they enter the hospital, they suffer from this virus, they need oxygen, and inflammation is starting to build up. If these patients do not improve or even deteriorate, they may have to be admitted to the ICU. And they'll have more respiratory support. They'll not just have low flow oxygen, but they'll have the high flow nasal oxygen, non-invasive mechanical ventilation, invasive mechanical ventilation even, and inflammation starts to play a bigger role. And we see ARDS develop, and sometimes it looks different from classical ARDS, where we have this kind of light ARDS and we have a heavy ARDS, and people get coagulation abnormalities. And then if we're not able to give them the right treatments and they deteriorate even further, ARDS starts to be more pronounced. And then we get these patients where we have to go through the same circle of differential diagnoses time after time, because we do not know if their deterioration is caused by, problems related to, for instance, atelectasis and ARDS, if they're still in this hyperinflammatory state, if they are suffering from their coagulation problem, or if they have secondary infections, including what we now call CAPA, so COVID-associated pulmonary aspergillosis. So that's kind of the clinical pathway that patients take if we are not able to treat them. So for me, that means that the treatment of this disease, you kind of break it up into three big chunks. So the first thing, and that's what Yazdan just elegantly explained, is the antiviral therapy. That is probably most useful early on. And then there is a big chunk of immune modulation, whatever that means. It includes a lot of different therapies. And then there's this anticoagulation problem that may be partly inflammatory mediated, or that may be a clotting problem, or both. I think that's also a very interesting research question and something we really have to keep investigating. For now, I'll focus on the middle one, so the immune modulating treatments, because that was my task for today. So I'll share my thoughts with you. So I think the first thing I wanted to share with you is this manuscript. I think we all know it. It was the New England Journal of Medicine publication of the Recovery Group, proving that dexamethasone works for hospitalized patients with COVID-19, and notably for those who need oxygen or non-invasive mechanical ventilation, or even invasive mechanical ventilation. So this is really a landmark study, and that shows from the metrics of the publication. So as you can see, there have been almost a million page views, and that's in less than 9 months, and it ranks 22nd amongst all New England Journal of Medicine publications ever. That's huge. So this is really a practice-changing study. And this was published half of June, 17th of June, 2020. And this is one of the graphs that I want to show you from that study. And what this shows you is in the blank diamond, so the white diamond at the bottom of the screen, I'll circle it with my mouse now. You can see that the overall results for all patients of treatment with dexamethasone 6 milligrams for 10 days or until they got better was significantly better. So dexamethasone was better in these patients. But what this picture also shows you is that there was an effect that was maybe most pronounced for the most severely ill patients. It was definitely still there for patients on oxygen, But for the patients very early in their hospital admission or not requiring oxygen, there may have been harm from this intervention. And we don't know why that is. It's a pragmatic study. But one of the explanations could be that if you block the immune system too early, you give the virus a chance and you give secondary infections a chance, and then your patient is worse off in the end. And something that is an argument for this line of thinking is the fact that the curves for patients without oxygen, where the benefit or where the control and the dexamethasone group kind of separate, is only about after a week or so. So that's the time you typically need to develop a secondary infection or an infectious problem. So that's what I think of the subgroups of the recovery dexamethasone trial. So then the question comes up, why did this trial so early on in this pandemic hit the bullseye with this therapy? Because I come from an ICU background, and in ICU in the last 25 years, there have been very, very few trials where we could actually prove a benefit for a group of patients. And I think there are a couple of explanations for that, but this may play a role. So in hospitals and especially in critical care, we tend to focus on researching syndromes. So we do research into ARDS or we do research into sepsis. But those are not diseases, those are syndromes. And the patients that are usually in that group are much more heterogeneous than the group that was now included in the recovery trial. I'm not saying all patients with COVID-19 are alike, because as you've heard, they have a variety of problems. They have inflammation problems, they have infection problems, they have clotting problems. But overall, they look much more alike than your typical ARDS population in an ARDS study or than a sepsis population in your typical sepsis study. So this for me means that focusing on a disease rather than a syndrome or enriching the population so that they look much more alike is a strategy we may want to retain even after this pandemic. So that's about corticosteroids. As Jesus told you, and as I disclosed at the beginning of this presentation, I'm a member of the REMAP-CAP investigators. We like to call ourselves the REMAP-CAP family because we really are a global group working together. And when Recovery published those results half of June, we had to stop a similar intervention in our trial, which was we were investigating hydrocortisone either for a fixed course of 7 days, 4 times a day, 50 milligrams IV, or the patients got hydrocortisone only when they were in shock. So that's what we called our shock-dependent hydrocortisone arm. So we stopped recruiting to that even before we hit our pre-specified trigger, because REMAP-CAP is a adaptive platform trial with a Bayesian statistical framework. So the way that it works is we predefine how sure we want to be that something works. And if we hit that finish line, then that part of the trial is finished. And then we declare that platform conclusion and we move on to investigate other interventions. So we stopped recruiting to hydrocortisone for COVID-19 patients, and we released these results early September. And what you can see here is the way we represent our outcomes. And on the right side, you can see the red and blue bars where we visualize our primary outcome, which is the number of organ support-free days at day 21. And this only relates to cardiovascular or respiratory organ support, where we define death as the worst outcome. So if you have -1 organ support-free days, that means you died anywhere during follow-up. Then we have 0 organ support-free days as the second last outcome, and then it goes on and on and on. So we have a 23-point ordinal scale primary outcome. And what you can see in the picture on the right side of the slide is that for the control group, so that's the upper bar, there's a lot more red compared to the intervention arm. So the control arm did worse, and that's depicted in a different way in the graph you see on the left side, where you see days free from organ support on the x-axis and the cumulative proportion of patients on the y-axis. And what you want to see in such a graph is you want to see it rise slowly. The more slowly a graph rises, the better it is, because 21 days of organ support free, being organ support free, is better than 0 days and is much better than dying. And what you can see is that the control arm rises more quickly than the intervention arms. So again, here it shows you that the intervention worked. And this translated into a 93% posterior probability. So that's the way we do stats in the Bayesian analysis framework of this trial for the fixed dose hydrocortisone, and an 80% posterior probability for the shock-dependent hydrocortisone that it works. So this is not about the magnitude of the effect, this is about how sure we are. So with 93%, we did not reach our pre-specified 99%, but this combined with the recovery results made us pretty sure that corticosteroids are effective in the treatment of COVID-19 patients. And the interesting thing here is that these results of the REMAP-CAP steroids trial, together with other important randomized controlled trials across the globe, were immediately in a prospective meta-analysis integrated, analyzed, and published together with the updated WHO guidelines on this subject on the same day. So this is really another excellent thing that has come from this pandemic. So we shared our data even before we'd seen the data ourselves or had published them. And the guidelines were able to be published on the same day as all these trials reported their results, which is really in the best interest of patients. So in the WHO guidelines, this is the definition of disease severity. So severe is defined, as you can see here in pink, and then they have critical in the more red color. And the conclusion in those guidelines was that corticosteroids work, and the evidence for that is strong. And shortly, we commend corticosteroids. That's the advice of these guidelines. And why did they do that? Because there were fewer people who died with critical illness, and there were fewer people who died with severe illness. And that was at the cost of a couple of more hyperglycemias, which I think is not surprising and very acceptable in the light of saving lives. So that's about corticosteroids. But that's a pretty kind of big, aggressive therapy blocking a lot of the immune system. And I think that success led us to search further to a more targeted therapy. And if you start looking for immune modulating treatments in COVID-19, you are hit by a wave of research because there's a lot of research ongoing, and it's very, very difficult to distill the important trials from that. So I hope I can contribute to that a little bit today. Here I have a visual from a website shown here at the bottom of the slide is the web address. And here you can see that there's just an amazing amount of research ongoing. This is only therapeutic trials about COVID-19 across the globe. And you can also see that, fortunately, many of these initiatives are not in a single country, but are collaborations between groups and between countries, which I think is very, very important. And just to take you back about 12 years to the last pandemic, so this is a slide about the swine flu pandemic. Very little research got done in that pandemic. What you can see here is that even though there were good intentions to enroll patients in interventional studies, but also cohorts, in the end, there were actually only 2 randomized controlled trials that were published. Only 73 patients in total from this whole pandemic that lasted more than a year, even though it was less disrupting than the current one. But 73 patients in a randomized clinical trial that got published. And both these studies got published only after the WHO released what we call the FIC, the public health concern across the globe. So that was pretty disappointing, and we're doing a lot better now. So what I'm going to try to do is to take that whole tsunami of research and bring it down to what you can use today or tomorrow in your site, and give a couple of reflections maybe about the future. But I hope to take not too much away from Massimo, who will also speak on that subject after me. So I think the thing that is spiking the most interest these days and these weeks is tocilizumab. That is an IL-6 interleukin-6 receptor antagonist, and in that way it's very similar to sarilumab, which is almost the same compound. So you would expect it to work very similarly, but we have much more trials on tocilizumab than we have for sarilumab. And if you want to break down the trials that have been done on tocilizumab, there are a couple of earlier studies that are all relatively small. all less than 250 patients. Another thing they have in common is they included not too severely ill patients. So they typically included ward patients on low flow oxygen, but none or the minority of the patient population were patients on non-invasive or invasive mechanical ventilation. So these are trials like the Stone study published in the New England Journal of Medicine. So that was the Back Bay study. Actually, Stone was the first author, and the Salvarini study. An important thing to notice is that these trials were conducted before the summer, so before the release of those Recovery UK steroids results. So patients in these trials did not have concomitant steroid therapy. That's a very important thing to remember. Kind of the last of the early studies was the Core Immunotosi-1 trial, which was already a little bit different because there was more steroid use in that trial. 33% in the tocilizumab arm versus 61% in the control arm used steroids. And there's a very interesting thing, because even though I have cut off the C aspect of this figure, so figure 2 consists of an A panel, a B panel, and a C panel. I've cut off the lower one. That shows you the day 28 mortality, and it shows you no difference between the groups. But if you look at the probability of death or mechanical ventilation, high flow or NIV at day 14, you can definitely see a difference between the groups to the benefit of tocilizumab. Also, for the probability of dying or getting to mechanical ventilation at day 14, there is a difference between the groups. So that's very interesting. It's not as negative as you may think. After these early trials, there were the 2 Roche trials, the COVACTA trial and the AMPECTA trial, that I want to discuss. And I'll start with the COVACTA trial. In that study, less than half was on steroids, and their primary outcome was a very short outcome. They looked at a difference at day 7 in an ordinal scale of clinical, a 7-point scale, I have to say, 7-point ordinal scale, not a 7-day scale. They looked at that at day 28 and whether there was improvement in this scale. And for that outcome, which was the primary outcome, there was no difference. But interestingly, they did see a shorter time to hospital discharge, and they also saw that the patients in the intervention group were less likely to progress to ICU admission. So that is interesting. For the AMPECTA study, it's a little bit the reverse of that. So they did see less progression to invasive mechanical ventilation or death in the intervention group, which again was tocilizumab. But if you look at the figure I show you here, where that is shown in the blue and right graph, you can see that the significance level is hit. The P is 0.04, but actually, because of the way this outcome is constructed, this is not a very robust outcome. So yes, they hit their primary outcome, but if you, for instance, look at the difference in mortality, you see no difference in mortality between the intervention, the tocilizumab group, and the control group. It's 10.4 versus 8.6%. So kind of summarizing, you can see that the early studies were definitely negative, but they had less than 10% of their patients on corticosteroids. And there are kind of some beneficial signals after that, but nothing quite convincing. Even worse, there was a study that suggested there was a potential harm from tocilizumab. This was the study by Veiga and colleagues, the TOSI-BREST study, which is the Brazilian study. And that had an adaptive design, was really nicely set up. But very unfortunately, after their planned interim analysis at 500 patients, the funding was withdrawn and they were not able to finish their study as they had planned. So that's very unfortunate. And it's also actually, I think, unethical as a funder to withdraw the funding. But obviously, I don't know the circumstances behind that. So I'll refrain from commenting on that further. There are a couple of other things that you need to remember about this study. So what I find very interesting and also a little bit concerning is that in the standard of care arm in this study that included hospitalized patients, there was only a mortality rate of 3% in the standard of care arm. That's very, very low. You'd expect mortality on the wards to be more like 10 or 15%, depending on which patients and how fast you can send them to the ICU if they deteriorate. another thing to realize is that there was a lot of hydroxychloroquine use and also azithromycin in the standard of care arm. So that may have influenced the results. And kind of in summary, because it was in the end an underpowered study, despite the elegant design, the results of this study do not exclude harm, but they also don't exclude benefit. There can still be benefit from tocilizumab in the patients included in this trial. That's not excluded by the results that we've seen from this study. So now I'm going to move on to the most recent results, which is the results of the REMAP-CAP study and also the recovery study that I'll get to later. And I'll just quickly take you through those results. So in REMAP-CAP, we analyzed 865 patients who got tocilizumab or actually sarilumab, so the other IL-6RA, at admission to the ICU. And they had to get that within 24 hours. And if you look at the manuscript that was published last Thursday in the New England Journal of Medicine, you'll see that they also got it after 12 to 13 hours. On average, these patients got their intervention. And we included patients suspected or proven to have COVID-19. We gave them 8 milligrams per kilogram of tocilizumab, capped at 800, so never more than 800 milligrams in total, as an IV infusion. And at the discretion of the treating clinician, that could be repeated after 12 to 24 hours based on the feeling of the clinician. For sarilumab, we only had a one-off dose, and we compared that not with a placebo, but with no immune modulator. Most of the patients were enrolled after the disclosure of the recovery results. And of those patients, almost all of them were treated with corticosteroids within 48 hours of admission to the ICU. There was also some use of remdesivir for those of you who are interested in that. We didn't do any subgroup analyses for that. That was not possible. And actually, most of the patients got the intervention. So 92% for TOSI and 90% for SARI did receive their intervention, and about a third of the tocilizumab group received a second dose, as I just described. In the control arm, about 2% did receive an IL-6RA, despite the fact that they were randomized to the control arm. So you've seen this before from the steroids results in this presentation, but this is how we represent our outcomes. So you can see the 23 different blocks for the 23 points of the ordinal scale. That includes death at -1, and then the number of days free from organ support up to day 21. And what we do is we calculate an odds ratio for that. And the way that works is it dichotomizes. So we compare, for instance, -1 to all the other outcomes of the to all the other points of the primary outcome. And then we calculate another odds ratio for the first 2 versus the rest. We calculate another odds ratio for the first 3 versus the rest. And that goes on and on and on for each dichotomization. And then in the end, we calculate a weighted average across all these odds ratios. And that's the odds ratio we present to you. But we also present it graphically. And this is the graph for tocilizumab and sarilumab. And I think it's very, very clear that there is a reduced mortality. There is also, and that's also described in the paper, a reduction in length of time that patients spend on organ support and in the ICU. And the median adjusted odds ratios for tocilizumab and sarilumab, respectively, are 1.64 and 1.76. And that translates into a posterior probability. Kind of how sure are we that this works? Well, that's over 99.9% for tocilizumab and 99.5% for sarilumab. So as an intensivist, I'd say we are pretty sure that this works. You can see the exact same figure I just showed you in the right upper corner of this slide. And to the left of that, so the upper graph shows you for the intervention separately in blue versus the control in red, the results. And again, this is the graph where you want it to rise more slowly, and you can see a clear separation between the interventions and the control. And if you look at the bottom part of this slide, you can see the same visualizations, but then for the pooled IL-6RA. So this is where we have combined the results for the tocilizumab and sarilumab arms. Was this a safe intervention? The short summary is yes, and that's something that comes back in all of these trials, even the negative trials. The number of SAEs is really, really low, and we don't really see an increased incidence of, for instance, secondary infections, something that you would maybe expect. But that is something that is taken from chronic use, and obviously we only give a one-off dose in those trials, or maybe two. We also showed less progression to intubation, ECMO, or death, as you can see from the progression rates, and these are tables taken from the supplementary material of the REMAP-CAP study. And if you break that down by component, you can see that it's for both death, intubation, and it's very hard to say something about ECMO because the numbers are really, really low. So in conclusion, I think REMAP-CAP proved that in critically ill patients with COVID-19, meaning they are admitted to an ICU and on organ support, treatment with the IL-6RA improved outcomes, including survival. So I also promised you some results of recovery. So recovery adds that the signal for benefit is consistent in the less severely ill patients if you give them corticosteroids. So these are graphs taken from the preprint that they released just over 2 weeks ago. And what you can see on the left side is mortality, where the tocilizumab arm does better than usual care because it's lower, and it's presented the other way around in the B panel on the right side of this graph, where you can see that the risk of being discharged alive, so that's a positive outcome, is higher for the intervention than for the control. And this is the last picture I wanted to show you for the recovery results on tocilizumab, because you can again see that overall the intervention is better than control. But what is very, very interesting is they also show it as a breakdown by use of corticosteroids. And this kind of shows you something that I've been trying to tell you in this presentation so far, is that the results seem to be very clear in the patients that used corticosteroids, but it was not significant, maybe even harmful in the patients not using corticosteroids. So I think that proves that we have to give these patients corticosteroids before we give them tocilizumab. So for me was that, what does that translate to kind of clinically? And in this slide, I've only depicted the immune modulating treatment. So I've not included the antiviral treatments or things to do about coagulation. I think if patients reach the hospital and are in need of oxygen, they are severely ill, and you should treat them with corticosteroids, and whether you choose hydrocortisone or dexamethasone doesn't really matter. If they then deteriorate or don't improve, and especially if they progress to high flow or NIV, I think you should add an IL-6 receptor antagonist. And we have to see if there are more treatments that can prevent these patients from deteriorating even further. And then if they are invasively mechanically ventilated or worse, they should have definitely already received their steroids. They should have definitely been treated with IL-6RA. If they haven't, you should give it. And then we have to think about other treatments for these patients, which becomes a little bit more difficult because they may not all be suffering from hyperinflammation anymore. There may be patients that suffer more from their ARDS, their coagulation problems, and there may be patients who suffer from secondary infection and are more immune paralyzed. So the picture there becomes a little bit less clear. So are there other interventions other than tocilizumab and sarilumab? Some have been investigated. So the Solidarity study also looked at interferon, showed that that was not beneficial, potentially harmful. And we have to kind of merge that with the results of a study in a different type of coronavirus, so MERS coronavirus, that showed that the treatment with interferon and then with Kaletra was good for these patients. So this is a study that was published last year by the group of Yassine Arabi. And you'd actually think that it would work in a similar way for SARS-CoV-2, but apparently it doesn't. So what is the difference then? Well, I think the timing is crucial. Unfortunately, there is a possibility that steroids worsen outcomes if you give interferon after steroids. So it's very hard to investigate this treatment now in patients who've already received corticosteroids, but there may still be a role for this treatment early. There's no definite proof of that yet. Another cytokine that I showed you very early in this presentation was IL-1. There are also IL-1 blockers. One of them is anakinra. There are a couple of trials ongoing on that. We are also investigating this still in the REMAP-CAP study, and I'm very interested to see those results, but we don't have them yet. I do have to say that there was a trial, and maybe even several trials in France, that stopped early because they saw a signal of harm. We looked at that extensively in our own trial. We didn't see it, or at least we didn't get a signal of harm from the Data Safety and Monitoring Board. And also in kind of studies at the end of the 1990s in sepsis, there were never safety concerns like that in these trials that were obviously not in COVID, but in sepsis patients. And we haven't heard any other safety signals since. So that's kind of still up in the air, and we have to see what that does. And then there are a couple of other very, very interesting compounds that I think need to be investigated as kind of a third-line treatment. And that includes things like JAK inhibitors, anti-GM-CSF, anti-TNF, maybe, therapies focusing on IL-17, maybe. And then, you know, many people have questions on continuation of steroids, high-dose steroids, later steroids. These are all things that we haven't investigated yet, and there's still a lot to learn about the best treatment for these patients in the hospital and in the ICU. So I'm looking forward to the future. And with that, I'd like to thank you for your attention and give the floor back to Jesus. Thank you.
Thank you very much, Lenny. That was a fantastic presentation as well. And I'm sure there will be quite a good number of questions. Now it's my pleasure to welcome my co-chair, Evelina Tacconelli, who finally managed to join us. So Evelina.
Thanks, Jesus, and sorry for being late in joining this incredibly interesting meeting. I'm very glad now to introduce Professor Massimo Antonelli, head of the Department of ICU at the Catholic University in Rome, Italy. I think his lecture is very much integrating within the other two and the wide spectrum of the COVID-19 disease. So he will be reporting about available evidence and prospect for treatment and management of ventilated COVID-19 patients. Please, Massimo.
Thank you, Evelina, for the introduction. Just a second. Oh, I do have a problem now. Okay. I'm so sorry, but I'm having some problems with sharing my screen now, even though yesterday everything worked perfectly. I'm trying to solve these problems.
Otherwise, Massimo, you can send it to me and I can project it for you.
No, it should be okay now. I don't understand why. Let's see. Well. Oh my God, I'm so sorry for these inconveniences.
It's okay, we have a bit more time to think about questions to ask you. If you want, Massimo, just send it to me and I will share my screen.
Okay, at least I can do that. But
yeah, and in the meantime, maybe you try to work on.
Yeah, okay. Well, let's see. This is really not understandable.
Is the cost of Zoom?
Yeah.
It happens to 1 every 3 speakers, and you were the third. So.
Yeah. Thank you very much indeed. This is encouraging. Oh my God. I'm trying to send you my slides. Well. Don't know what to do. If you want to start the
Yeah, maybe I was
at
thinking,
least,
Massimo, we can ask maybe a question to Lenny just until you solve your problem, and we just save some times for the question. I would like to ask you, Lenny, just a very wide question, I would say. But my impression now, after many months on COVID-19 patients, and I think your presentation was just going on the same direction, is that we are starting talking about personalized therapy for COVID-19 patients. That is very much resembling what we learned from antimicrobial resistant infection, just moved on the COVID-19 patients. What is very difficult to me at the moment, and you try to give some of this answer at the end of your presentation, is to identify which are the criteria for these phases. Did you get your idea about it based on your experience in the trial?
Yeah, thanks, Evelina. That's a question that occupies me many times. So I think the patients that Recovery identified that benefit from steroids are kind of everyone that's admitted to the hospital and on oxygen. So to me, that sounds like a first-line treatment for those patients. And I don't think I would hit them immediately with tocilizumab, because I think that may be a bit overkill. And note that they did tocilizumab as a second randomization in their study. So they included only patients who became worse and who had a CRP of over 75. So whether you should definitely go with that criterion, that study criterion, I don't know. But I would take some time to see if patients benefit from corticosteroids, and as Yazdan said, maybe even remdesivir for those patients on the ward. That's a matter of how you interpret the evidence that there is. But then if patients progress quickly, or if they even kind of enter the hospital more ill on high flow or non-invasive mechanical ventilation or directly to the ICU, those patients, I think, should receive tocilizumab unless they have an exclusion criterion, because evidently in the trial, even though we tried to be pragmatic, we did have exclusion criteria like pregnancy or having ALT or AST above 5 times the upper limit of normal, or being chronically severely immunocompromised. So for those patients, you have to be careful because they were not included in the study. And then I think the next interesting question is, can we then prevent many people from reaching the ICU if we give that before they become invasively mechanically ventilated? And for the people who remain, I think we need to think about the best so that's why I called it third line treatment, because I think you should try the first two first before you try anything else. And so that's a little bit of personalization. About CRP, in our study, we did a pre-specified subgroup analysis by CRP tercile, and we saw that the effect was in the same direction in all the groups, although it was the most pronounced in the most severely ill groups. So that's what I can say about that. Yeah.
Yeah, that's resembled very much also my clinical experience. Would you like to go further with question, Jesus?
Yes, I think Yazdan have a question. So first, Yazdan, please.
No, I just,
or a comment, or a comment on that.
Yeah, a comment. Just hi, Evelina. No,
hi.
No, just regarding Lenny. So that is what I said. I think that we have steroids now. We have tocilizumab. So I think that in this inflammatory stage, we probably need an antiviral. So that is what I said, and you stated, Lenny. I completely agree. However, personally, I don't think that we showed in Discovery that probably, Solidarity, that remdesivir is not active. I think that we are now conducting with NIH a meta-analysis to try to really find out that. But I think that we need an antiviral. I'm not sure that antiviral is remdesivir. Just wanted to state that.
Yeah, and in addition to that, talking about personalization, as Evelina asked, so it's actually, if you would have told, intensivists a year ago that the treatment that they would be giving is not an antiviral, but is two things that suppress the immune system or block part of it, I think that's very surprising. And for other viral pneumonias in the ICU, we've always been focusing on antiviral therapies, but maybe that's a dogma that we have to challenge and that we have to investigate. Because now we see that at least for this disease, so remdesivir on the ward, I think you clearly explained that, Yazdan, but in the ICU it doesn't work. So people apparently kind of passed that stage, and then just suffering from the overreaction of their immune system, whatever that exactly is. That's interesting.
Look at the slide, Evelina.
Yes, so I will share it now.
So sorry for that. Okay. So please, the next one. The only thing I can do, this is my conflict of interest. The next one. Very recently has been published the leading guidelines from the Society of Critical Care Medicine in the United States and European Society of Intensive Care Medicine that Lerny and myself belong to. And this is a leading guideline. This is the revision, the first update after the previous edition that has been published months ago. The next slide, please. The first thing that I guess is important to draw your attention on the most critical patients, and just to look at the definitions that are contained in these guidelines. And indeed the boundary between the severe situation and the critical ones is indeed quite faint. However, similar to what has been described by Lenny in her presentation, the clinical signs of pneumonia, such as fever, cough, and one of the following in terms of increased respiratory rate, severe respiratory distress, or desaturation of the oxygen on room air below 90%, represent a severe category, as well as the critical ones are indeed characterized by the presence of the acute respiratory distress syndrome or failure requiring ventilation, sepsis, or septic shock. A necessary premise to my presentation is that, of course, including into the armamentarium of the various therapies, there are also the ventilation therapies, and I will allude to them also because part of these therapies may be also applied outside the ICU in the early phases of the severe condition. The next slide, please. If you look at the resources and the recommendations contained into the adjournment of the guidelines, the systemic corticosteroids, both in severe and critical patients, got the green light, as well as the dexamethasones that can be considered most on top of the other corticosteroids, even though there will be no specific recommendation in favor of one of the two. And another things that I wanted to allude to, we'll do in a next slide, in the various next slides. No, please go back in the previous one. Is the pharmacologic prophylaxis of the venous thrombosis. For what concerns the patients who are only severe, indeed the remdesivir may be an option. But for those who are critical and undergoing mechanical ventilation, the remdesivir is indeed not prescribed. And what concerns the convalescent plasma outside the clinical trials is recommended to be avoided, and the full anticoagulation should be included into the armamentarium or the outside the clinical trial, without outside the clinical trial. And the other big problem is to not use hydrochloroquine anymore at all. The next one, please. Next slide, please. If you look at the evolution of the hypoxia, the various indications, depending upon the endotracheal, if the patients may undergo the endotracheal intubation or not, you have a series of intervention that pertains also the various precautions that the staff need to follow in order to prevent any contamination. And if you look at the possibility that patients may tolerate the supplemented oxygen, it's important to keep in mind that we have a narrow limit, a narrow range between 92 and 96 that should be achieved with appropriate infection control. And if this supplementation is not enough, then we have to consider the high flow nasal cannula. I will come back on that later on. Ultimately, if the patient do not respond, one option may be the endotracheal intubation. Next slide, please. And finally, if you subdivide, categorize between mild RDS, severe RDS, and rescue therapy, then you can have some recommendations regarding the way in which ventilate the patient, which is a protective ventilation, how we have to behave in case of suspicion of bacterial overinfection, and having an approach with conservative fluid strategies, and at times consider the antibiotic therapy. For what concerns the patients who have a formal RDS, the moderate or severe, then in this case, we have to increase the PEEP or use as well as, taking into consideration the possibility of administering the neuromuscular blocking agents with some other possibilities, such as the prone ventilation or the infusions of continuous infusions of neuromuscular blocking agents. Prone ventilation is another option, but there are ultimately, when the patient do not respond to the various approaches, then the venous ECMO, referring to ECMO center, may be the real final solution or final possibility. The next slide, please. If we compare the previous guidelines that published months ago to the new evolution, we can see that if for what concerns the patients in mechanical ventilation, there is a clear-cut recommendation in this new adjournment regarding the corticosteroid. This is a strong recommendation with a high quality of evidence showing a reduction of mortality rate and with minimal adverse effect and are widely available. Is one of the other reasons why it's strongly recommended. During the first phase, the use of systemic corticosteroids suggesting dexamethasone or other corticosteroids was not applicable. But always you have to remember with the new recommendations that if the dexamethasone should not be available, then can be used other corticosteroids in dose equivalent to the 6 milligrams daily of dexamethasones up to 10 days. However, for the moment, we have to say as a justification of the statement that there are no real trials comparing the different kinds of steroids, and then they are considered for the purpose of treatment as substantially equivalent. The next slide, please. Another important point concerns the use of remdesivir that has been alluded to before by the previous two speakers, is exclusively recommended for those patients who do not require mechanical ventilation. And even though this is a weak recommendation resulting from relatively poor studies that showed a reduction in the time of recovery and the hospital stay, this could be out of question for what concerns patients who are indeed more severe or mechanical ventilated or receiving high flow oxygen therapy and not conventional oxygen. And the other important point that for those patients who are under mechanical ventilation already, since the very beginning, despite the limited data on the outcomes of these patients, this is considered not recommendable, and this is a weak recommendation. The next one, please. The next slide, please. Once again, and finally, no, the previous one. May I have the, thank you. The other two important points regards the convalescent plasma that was already illustrated into the cartoon, and for which, due to the low quality of evidence of the various randomized trial that didn't show any improvement outcomes, for the moment, this is only recommended for the clinical trials, and the final ultimate results we should give us a clear-cut indication. The other big point is the use of the anticoagulant. That whilst in patients who are outside the ICU in the early phases, the use of anticoagulants due to the various possibilities of developing venous thrombosis or pulmonary embolism in these patients may be recommended. This is not the case for patients who are under mechanical ventilation and admitted to the ICU. Probably for one simple reason, that all our patients admitted to the ICU receive already the thromboprophylaxis, and the conclusion when you go to compare the possibility of using the anticoagulation together with the thromboprophylaxis, there is no real clear-cut evidence on the possibility that the anticoagulation may be superior in ameliorating the outcome respect to the thromboprophylaxis. The next slide, please. I want just to address your attention for a while, but I don't want to insist that much because Lenny has already elucidated the details concerning the use of the interleukin-6 receptor antagonist, that when the REMCAP investigators trial has been published in New England, simultaneously there was another paper that was indeed not as good as the one, always considering severe patient with pneumonia. Next slide, please. And whilst we know that, the next slide, please. And whilst we know that concerning the critically ill patients in the REMCAP study, the outcome was strongly in favor for those patients who received the tocilizumab or sarilumab, improving the survival rate. This was not clear enough for what concerned those patients belonging to the other trial, and where by using similar dosages, there was not significant results improving the outcome or lowering the mortality respect to the placebo 28 days. There are probably several reasons why these two trials may not have the same similar results, probably because the kind of patient that were enrolled were slightly different, and this heterogeneity may just explain some of the differences. So whether one personal consideration is that in the REMCAP trials, we do not have enough indications concerning the evaluation of the IL-6 level in the plasma. And probably one of the future question mark and investigation should be focused on addressing the possibility that tocilizumab may be more or less active depending upon the level of IL-6 into the plasma of the severe patients. The next one, please. But if we do have some pharmacological possibilities for treating these patients, we have also to consider that also the oxygen therapy and the mechanical ventilation represent a therapy. This cartoon illustrates the bench of interventions that has been proposed after the Berlin definition of ARDS. And some of these interventions are strongly specifically allocated depending upon the severity of the syndrome. The next one, please. One of the things that I want to address your attention concerns the use of high flow oxygen therapy. The next one, please. We can try to address why this kind of way of delivering the oxygen may be beneficial. Indeed, when you use this kind of oxygenation way, we use a high flow inspired gas up to 60 liters per minute with full humidification, which is equivalent to almost 44 milligrams of water per liter. And the adequate humidity is a big advantage, but at the same time, the high flow rate is a washout of the dead space, improving the clearance of the CO2. And the high flow rate just working as a expiratory brake can generate some small amount of PEEP and increasing the end expiratory lung volume, increasing the recruitment and improving slightly the compliance. All these different effects may work on the work of breathing, reducing it, improving the respiratory drive, decreasing the respiratory rate, decreasing the respiratory volume, and ultimately translating into a better comfort. The next slide, please. I guess that probably what the first study that can declare the popularity of high flow oxygen therapy was the coming from Jean-Pierre Frat in France and the French group, the REVA network. The next slide, please, where the investigators were capable to show that the approaching patients with severe hypoxemia by using high flow oxygen therapy in comparison to non-invasive ventilation and standard oxygen translated into a lower rate of intubation of these patients. The next one, please. And looking at also to the patient who were more severe, whose PaFTO2 was below 200, this effect, at least in that population, was much more pronounced. Next slide, please. Finally, if we look at the populations that represented the entire population enrolled in this study, all of them had bilateral pulmonary infiltrate, and their PaO2 was in large part below 200. So we are speaking about quite severe patients. Next slide, please. The next one. Next one. If we look at how it has been applied into the patient who are specifically affected by SARS-CoV-2 and with a moderate to severe hypoxemic. The next slide, please. In this publication of BMJ, enrolling a number of patients that ultimately received in 104 high flow oxygen therapy and nasal cannula, translated into some advantages, not in terms of mortality, but the next slide, please. In terms of improving the respiratory rate as well as the pulse oximetry, that's starting from a very low rate at the very beginning of the study. The next slide, please. And the survival probability, however, even though this is a retrospective study, showed that there was an association between the high flow oxygen therapy with the reduction of the rate of invasive mechanical ventilation, as well as the mortality rate in this category of patients. The next one, please. Another way to treat these patients inside and outside the ICU is the use of an helmet. which is a hook which is placed over the head of a patient, creating a pressurized environment where the patient can breathe and help to breathe with some pressure support modes. The next slide, please. In that original study, we could show years ago, and we are not speaking about patient with COVID-19, but severely hypoxemic patients, that those patients who received the helmet in comparison to face mask non-invasive ventilation had indeed a better outcome in terms of possibility of reducing the number of intubation and increasing the tolerance by applying also higher level of PEEP. The next slide, please. The next one. I guess that by use this kind of device outside the ICU into the context of the COVID-19 patients represented also an advantage in terms of prevention of environmental contamination. Indeed, when one of those patients sneeze or cough, create a sort of turbulent gas cloud that has the possibility of expanding over 7 or 8 meters far away from the patient. So having the possibility that by using the simple oxygen therapy, there will be a diffusion into the environments of the droplets and the aerosolized particles that can contaminate and create a contagion for the personnel. As soon as under this context is used the helmet by placing an HEPA filter at the expiratory port where the PEEP valve is located, this phenomenon is drastically reduced with a clear-cut benefit also for the personnel in terms of reduction of the contamination. Next slide, please. And the paper that showed after hours that was an observational trial, but this one is a randomized trial, came from Patel, who published in the JAMA the benefit by using the helmet on the face mask. So a form of non-invasive ventilation that under certain circumstances may be also used outside the ICU. The next one, please. And interestingly, this can be applied on spontaneously breathing patients outside the ICU, just placing the patient prone and improving, thanks to the body position, an additional benefit in terms of improving gas exchanges and finally outcome. The next slide, please. In this study, as soon as the prone positioning by using the helmet has been used, there was a dramatic improvement of PF ratio over the time. And any time that the patient were put again prone, this benefit was achieved again until the moment this was more stable. The next one, please. I want also to stress the attention on the implication of our national trial conducted in 5 big ICUs in the country, where in mechanical ventilated patients, we were capable of identifying 4 different phenotypes. Patients who had high dimers and low pulmonary compliance, high dimers, high compliance, low dimers, high compliance, and low D-dimers and low compliance. The next one, please. And looking at the evolution and the outcome and survival of these patients, the category that represented the most dangerous one, in which the risk of dying was certainly higher with respect to the others, was the combination of low compliance and high dimer concentration. The concept may be that we can try to differentiate our intervention, titrating the possible pharmacological interventions illustrated by Lenny and Yazdan into specific categories. This is just a proposal and can be at least incorporated in prospective randomized trials, this subdivision on the various phenotypes. Next slide, please. I want just to give you just some data concerning the first population published so far during the first heat of the pandemic in the very north of Italy and published into the JAMA. In the next slide, and looking at the characteristic of these patients, you may see that in terms of mechanical ventilation, large part of them received the invasive one, but part of them, even though a minority, had indeed non-invasive ventilation and oxygen masks. The next one, please. The evolution of this observation enlarging the number of patients that has been enrolled up to almost 4,000. The next slide, please. Showed how the multivariable proportional hazard regression analysis looking at the factor associated with mortality just stressed how the conventional conditions, but even the use of respiratory support, probably because those receiving the invasive mechanical ventilation were also those who were more severe, represented a factor that may anticipate or may be associated with a higher mortality rate. The next one, please. Which are my conclusions? That both high flow oxygen therapy and non-invasive ventilation, and this may be a good message, can be used in the early treatment of the acute respiratory failure due to the SARS-CoV-2 also outside the ICU. And this pertains, as we had to experience during the first heat, the possibility that overcoming the capacity of the various healthcare systems and hospitals, we can treat these patients. They may be a bit more severe outside the ICU, even though the careful selection of the patient may be fundamentally. Dexamethasone, early remdesivir, out of mechanical ventilation, and thrombovenous prophylaxis, but not anticoagulation are recommended. Finally, the IL-6 receptor antagonist may be an option in critically ill patients, but I guess that maybe we'll need to better, as asked Evelina to Lenny, a better indicator to address our therapy and getting the best benefit for our patients. Thank you for your attention, and I must apologize for the technical inconvenience.
Thanks, Massimo, for the excellent lecture, and also for reminding us how much important is the multidisciplinarity approach to the COVID disease. I think that people of our age remember very easily the HIV disease and how much important was also there, but was a very different, was not in the acute phase. So here it's really impossible to deliver the best care without a multidisciplinary and wide approach. So thanks for underlining that in your presentation. I will now leave the floor to Jesus to open the discussion by question received and by our question.
Thank you very much. Well, I anticipated it would be a very fantastic session, and it was. Thank you very much to the three speakers because they did a fantastic job. We have some question from the audience and also some questions that I received from other colleagues. So let me start by a very general question, but I think that has been somehow discussed, but I think it is relevant. So we've seen that for some drugs, the result of different trials do not always provide the same answer. Is that an issue of the type of patients included? Is that an issue of the efficacy of the drugs are not that consistent? Everything together, what would you say? And how do you apply this to the next design of your trials? We are lucky to have a panel that is very experienced in this issue. So I wonder how do you manage in your head how you're going to deal with this? Maybe Justin, you can start.
Yeah, thank you, Jesus. So I think that this is something strange that we have never seen. I think that so many trials with so many different results. I think although we have never seen something like that, so we don't know. But I think that probably that the reason for this, I think, is that of course we have this different population, and the other thing is that multiple diseases. We are not in front of one disease. And I think that what Evelina said is extremely important. I think that we should really try to find a personalized way of treating this disease, because this disease is really different stages of disease. And what is lacking is that we are always trying to treat, which is normal, but I think that we should first try to better understand this disease. And for example, we chose a CRP of 75 or 100 or 150, but before choosing a CRP of 75 or 100, maybe we should try to see how this actually is associated with the severity of the disease. So I think this is what makes it very difficult. The other thing that makes it very difficult is that we have different type of drugs, antivirals, immunomodulators. We know approximately where to put it, but much better than in the beginning, because in the beginning, I don't know you, but we were putting remdesivir at the end stage diseases, which is completely wrong. Now we know we should put it much. So I think that we should really take this disease as many different diseases. I think in our clinical trials, we should add personalized arm, which we are saying since 6 months. We should take it as a continuum and not say this is ICU patients, it is a continuum. And we should better understand the natural history, and we should really through cohorts, and Evina is here who is leading the cohort effort in Europe. I really think that we need much better, and not only clinical, but also much more. And the fact that we have all these big trials with very small number of biological data make it even more difficult. So I think that it's now very much, trials big, but that we have much more granularity data will help us also to understand.
Thank you. Lenny, what would you say about this?
Yeah, so I think there are many different angles to this, and they're all interesting. So I fully agree with Jastan that, we think we have the biomarkers. So I think somebody also asked a question on kind of what IL-6 level do you give an IL-6 receptor antagonist? We just don't know. So we don't know if we can stratify by CRP, and the same goes for anticoagulation. People assume that we can stratify people by D-dimer levels, but we actually don't know. So we need to find out a lot more. So integration of the trials with biological data is very important. I think there are two other interesting things. So I think this pandemic has taught us two important things. One of them is we never treat patients with one drug. We give patients kind of regimens of drug. We give them an antiviral plus or minus dexamethasone, plus or minus a specific immune modulator, plus or minus a certain anticoagulation strategy. And we really need to move towards investigating those regimens of therapy rather than pretending it's 1948 and we are comparing streptomycin to nothing in the treatment of community-acquired pneumonia. We kind of, hospitalization now is very different from 60 or 70 years ago. And another thing that's very evident in the pandemic is that it's challenging to do trials if the standard of care is rapidly changing. So that is why I am a passionate fan of adaptive designs that can incorporate all these changes and can kind of go with the flow in the pandemic and still give you important answers. So that would be my reflection on that.
Thank you, Massimo.
I guess that what Lenny was saying is the essence. Indeed, looking at what happened during this year, we know quite well that when we start in treating these patients, a disease that we didn't know at all, because nobody knew about the COVID-19 or SARS-CoV-2, you can call whatever you like. Indeed, we try to apply some logical consideration to our therapy, some that was physiologically plausible, that after some investigation denied in terms of efficacy. So we need, as Lenny explained, to adapt to a continuous evolving things. Remember that the story of the hydroxychloroquine, or for instance, the combination with azithromycin constantly. Well, the granularity of the information that can help us takes time to be achieved. And then we have to be open not only to the collaboration, but also to capability to adapt to the evolving knowledge. I guess, however, that also for personal experience, that looking at some biological parameters may be an option. I can tell you what we do, what we have done in practice. We have used the tocilizumab and sarilumab for many patients, but after that, we developed, I do not know if this is correct strategy, to reserve the use of these drugs, of these monoclonal antibodies, only to those patients who had a higher level of IL-6 in their blood. But as Lenny said, what high means is above 500, above 1,000 picograms per ml, is above 100, don't know. So what we have done was somehow arbitrary, trying to combine a relatively low level in comparison to other patients of the IL-6 with the clinical picture of these patients. And if probably the situation was relatively stable, we gave up, we abstained to administer the IL-6. But once again, I don't know. I think that we need to know more and more, performing several trials before having one recipe that can be good for anybody.
Thank you. Evelina, would you continue with some question?
Yeah, I mean, following up on what we have learned in this 12 months, I think that is also COVID-19 is a very nice expression of what translational approach in infectious disease means, because some of the questions that we ask a trial to answer are very much coming from the daily observation at the bedside. So from medical doctors or nurses without maybe a specific background in biostatistic or advanced study design, but still from the observation, you raise question from research. And then the evidence base that you receive is in 1 month old, and you have already new question that you should answer. So I'm following up now with some of the question in the chat. And many of our colleagues are asking you to make a comment about dexamethasone, in particular about high dosages, because again, how many among us are really giving 6 milligram as a request, and how many are by instinct in some patients increasing the dosage, because by experience you notice that in some patients increased dosages, you are getting better result a specific way. And the same for the duration of therapy in slowly answering patients. Some of the colleagues are asking, do you do it? And which are really the parameters that are driving your decision to start dexamethasone? So maybe Lenny, you can start answering, and I would like Yazdan and Massimo to comment as well.
Yeah, I think these are excellent questions, and these are the things that clinicians struggle with. So I think kind of in the earlier phase of the hospitalization, I would really recommend to use the doses that we used in the trial. So there's a bit of variation, but if you look at the WHO guidance, they have some kind of equivalent doses that you can use. But then the question is, even kind of if they've had it for 10 days and they still deteriorate and they hit the ICU, do you then continue it or stop it? It's a difficult question. And if you give high dose, when do you give that? And or should you start with the higher dose? These are all questions that we still have to answer. And I think the interesting thing about this disease is that even though it's such a complex disease that needs multidisciplinary approach, extremely interesting. The phenotype at the bedside is actually boring doctors, because every time they deteriorate, and it's always inflammation or ARDS or coagulation or a secondary infection, and we have to go through the whole motion of things all the time. And the question is if that changes with the therapies that we have now. So that is something I find really interesting for the coming months, to see whether that picture will change. For instance, will we have less thrombotic events if we use more immune modulations relatively early in the disease? I don't know. So these are things that are very important to observe at the bedside. So I echo the importance of observations of how it's going related to what we want to investigate in trials. There are many unanswered questions.
Yazdan, would you like to comment as well?
So basically, I can say what we are doing. We're doing the same thing as Lenny said. Regarding steroids, we actually before discovery, before recovery, we were putting higher doses, to be honest, in the clinic. But after, and probably you too, I imagine, and after recovery, we were putting 20 milligrams. But after recovery, we come back to 6 milligrams. And now, as Lenny said, if the patients are doing less well, then we increase to 20 milligrams. But that is not, of course, evidence-based. So there is a study now, they have enrolled in France more than 600 patients. It's only in ICU, and they have finished enrollment comparing in ICU 6 milligrams versus 20 milligrams. So maybe that, and they, but only in ICU, not. And then on the top of that, I don't know what is tocilizumab is going to do, because some of the people here are saying rather, although that is not going well with the fact that Toci and steroids are better than Toci without steroids. But here some people say if you increase the dosage of steroids from 6 to 20, it will do as well as Toci. So you see many questions, I agree. But this study 6 versus 20 in ICU, they don't have Toci, because we were using, because we had a study in April showing that Toci in a clinical trial, but small, that is working. So in France, many people use Toci, but before ICU, not at the ICU, really before when the inflammation is going up. So that is where we are. So many questions rather than answers. Sorry, Evelyn.
No, that's fine. It's stimulating doctors to ask themselves questions. Massimo, I saw you wanted to make some comment, and can you take also this opportunity to comment a bit high flow oxygen versus NIV by age and pulmonary comorbidity, which drives your decision?
I guess that as Yazdan said, there are a number of unanswered questions. However, let me, in a few seconds, recapitulate why or from where the 20 milligrams came from. In a very similar period has been published in New England, another study that was conducted into Brazil and in ICU patients, in critical care patients, and where the combination of dexamethasone was indeed delivered at 20 milligrams the first week and 10 milligrams the second week. Consequently, there were for a while people administering these combination, and others the 6 milligrams coming from the other study. I guess that for answering finally which one of the two is better, even though dexamethasone 6 milligrams per day is what is widely done at the moment, we have to wait the French study. For what concerns the high flow oxygen therapy versus the non-invasive ventilation, this is a never-ending story, a dispute between we as Italian and the good French friends. Indeed, they are strongly in favor of the high flow oxygen therapy, and they try to demonstrate that it's better than non-invasive ventilation. Well, I can anticipate you that we have just concluded in the COVID-19 a randomized trial, multi-center, that compare the two techniques, and we have a strong hope that it will be published quite soon in a good journal. So I can anticipate anything, but I can tell you that something is interesting. Will be interesting.
You know, Massimo, French ICU, I'm not ICU, I'm infectious disease, but French ICU that says that Italian ICUs are extremely competent and expert. What they say.
Thank you very much.
No,
but I say the same of my French friends. And for instance, in France, Elie Azoulay is not as in favor as other colleagues, French colleagues, for the high flow oxygen therapy. So as always, the world, the scientific world may have different positions based upon probably different populations that has been treated and involved and enrolled in the various trials. But may I ask a question to Yazdan, please?
Yes, of course.
May I? Yazdan, you said that the monoclonal antibodies may be not active against the Brazilian or the South African variant. Do you suggest then that in the future, if we want to use the monoclonal antibody, we have to sequencing first the patient before administering the monoclonal antibody? Is that feasible and rational in your opinion?
So first of all, I said that BAM, which is the Eli monoclonal monotherapy and Eli dual therapy, none of them are active against the South African and Brazilian. Regeneron, which is two antibodies, one of them is active and one seems maybe active. We should have more data. So we have the same question that you suggest. The issue is that if you do sequencing, then you cannot start early and you need to start within, we have said within 5 days, if not. So sequencing and starting early, it is not really compatible. So what we have said is that if the prevalence in your region is less than 10%, you can go. If it's more than 30%, you should probably not use. And between the two, you should try at least to, you know, this kind of PCR, which is not sequencing, but you can have this at least an indirect way of saying, see if you have, you should do that. So this is the strategy that we have adopted since a week, because you have a lot of, Evelina and Massimo, you have a lot of monoclonals currently in Italy, I've heard.
Not that much, at least not in the ICU.
But Evelina, you have
So we have IFA together with the German authority. They approved the emergency use for monoclonal antibodies in the first 10 days. As the FDA did, but we did not. So we are ready. We have already the net for doing and the organization, but the drug has not been distributed from IFA to the regions. So I'm expecting in a very few days to start, but with the exception of 2 small trials, there is no usage of monoclonal antibodies in Italy at the moment.
Okay.
I don't know, Jesus. Yeah.
Yeah, there are a couple of questions. There's a couple of topics that our attendants also address. One is related to relapsing COVID-19 management. Not that frequent, but it's really difficult to do. Of course, there's no evidence, but what do you do with relapsing, particularly immunosuppressed patients?
Yeah.
When
so, Jesus, we have started emergency use of plasma, convalescent plasma in those patients. We have more than 300 or 400 patients but really specific patients, where the kinetic and the clearance is very long. But plasma convalescent is not always well tolerated. You know, we have had some issues with that. So, and now the issue is whether we should use or not, because we're going to have monoclonals in the patients. Of course, the problem and the issue, as I said, is the risk of the emergency. So probably what we're going to do, probably we can use, but only dual therapies, not monotherapy. But we haven't started that yet. But it is an issue, I agree.
Yeah. And there's a couple of questions on related to anticoagulant therapy. So questions are related to dosing for all patients, whether only prophylaxis or some patients go initially to anticoagulant dose. What happens if a patient with anticoagulant dose develop an event? Do you use even higher doses? Any other preventive measures for that? Maybe Massimo can comment on that.
Yes. If you are referring to pulmonary embolism, for example, in these cases, we increase the dose, of course, because there is a clear-cut clinical indication. To some extent, there is the risk of spontaneous hemorrhages. We have seen in some patients where we increased since the very beginning the higher dose of anticoagulants, some huge hematoma of the iliopsoas. And it happened at least in the last few months, sometimes. So if on one hand, we may say that in presence of certain complications such as pulmonary embolism or deep thrombosis, the increasing doses of the anticoagulant may be rational. Nonetheless, this is also often related to potential high-risk complications. So, in my opinion, we need to be careful, and knowing at least into the setting of patients with the more severe conditions, where the thromboprophylaxis showed to be substantially better than the anticoagulant, we should stay with that, apart from specific indications.
Thank you.
Yeah, maybe in the last, sorry, yes.
No, go, Irina, please.
No, just if they can have 1 minute each for a comment on the role of baricitinib, the way they see it now. Yes, done.
Am I the best person for this question?
Yes, that's why I ask you.
No, in France, we do not use at all baricitinib in practice. Of course, as you know, Evelina, and as Jesus know, the idea is to try to start a clinical trial in patients with severe disease, and only in patients with severe disease in EU response and Solidac, to try to evaluate baricitinib. And the issue is that now that we have tocilizumab that is going to become a standard of care, what we should use. Whether the big infectious disease specialists like Jesus and yourself, you think that we can have steroids plus tocilizumab plus baricitinib or not. So what has been decided, but I put that in the table, is that probably we cannot, and it's better to say we use steroids plus tocilizumab versus maybe steroids plus baricitinib in a real specific population, which is patients with inflammation and patients who are at higher risk of inflammation, to go to the ICU and ICU patients. So that was the answer you wanted, or it's not good for you?
It's the answer I wanted. Thanks, Yazdan. Lenny?
Yeah, thanks, Evelina. So this is interesting because, as Yazdan has said, the standard of care is changing. And so if we want to investigate baricitinib now, we have to think about the patient that are non-responders to dexamethasone and tocilizumab. And then we have to figure out who kind of a priori is the most likely to benefit from it. So then we'd have to try and select the patients that are still kind of hyper-inflammatory after they've received those two, and then give them baricitinib on top of that. And I come from an ID background, so I know it's scary to give three drugs that are suppressing parts of the immune system in patients with an infectious disease. But you have to realize that rheumatologists are doing this all the time. They are combining these drugs, 2 or 3, for a length of time, much longer than an ICU admission. And may I remind you that you referred to HIV, and this is these were antivirals, I know, but also their combination therapy seems to work the best. So I am convinced we will not find one golden bullet, and we'll have to have, I don't know, step up or step down or tailored treatment. And I think the most difficult thing is selecting the patients who will benefit from a treatment like baricitinib, because we can think that we can use CRP or IL-6 or I don't know what biomarker you want to use, but it's very, very difficult. So yeah, there's interesting times ahead, and there's still enough questions to answer. I think, one thing that is close to my heart is if you want to use that type of medication, I would suggest you do it in a trial, because you can learn something as a person, but as a community, we can only learn if we kind of really pull the data together from different countries and different groups, and then try and, make the best sense of that.
Totally agree. Massimo, very last comment.
I substantially share the view by Lenny. I would just add a comment that we as intensivists, and Lenny knows this very well, we were frustrated by the constellation of failing trials over the last 20 years trying to resolve the inflammation. And indeed, we learned that what is physiologically or pathophysiologically plausible not necessarily translates into a real benefit. So we need to be careful and try to conceive a trial with a very, very thorough patient selection.
Amen.
So, thanks. Yes, thanks from my side. I leave it to you to close the meeting.
Thank you very much. Well, I said at the beginning, it's been fantastic to have 3 big speakers dealing with this topic. It's good that we have a lot of questions to answer, not that good for the patients, but good for our reasoning, and individualized medicine, as Evelina said, will probably be something to work on in the near future. Already we are trying to do that. I think some of the questions that were not answered we will be able to answer them on writing, and our audience will have access to that later. So thank you very much, everyone, for joining. Thank you to the speakers for preparing this fantastic presentation that will be available for everyone for a while. And thank you very much for taking care of COVID-19 patients in these very difficult situations to everyone in our audience. Thank you very much.
And looking forward to our collaboration.
Of course.
Bye-bye.
A special thank to Evelina for the technical collaboration. Sorry for
that was a pleasure. Bye.
Bye.